Welcome to the Gus Alva Perspective, a podcast that's earmarked to address novel points of neuropsychopharmacology. Today, I'm particularly excited about sharing some time with a dear friend, Dr. Jonathan Meyer. Dr. Meyer is a voluntary clinical professor of psychiatry at the University of California in San Diego and a distinguished life fellow of the American Psychiatric Association. So we share that particular accolade. Dr. Meyer is a graduate of Stanford University and Harvard Medical School, so a serious pedigree here. More importantly, Dr. Meyer has lectured and published extensively on psychopharmacology. He's also helped out with Dr. Stephen Stahl, who is another dear friend of ours and is a co-author of the Clozapine Handbook, which was published in 2019, and the clinical use of antipsychotic plasma levels released in 2021, as well as the Lithium Handbook published in 2023, all three by Cambridge University Press. Jonathan, tell us more about this particular area that you are excited about.
Well, really, Gus, we have experienced a revolution in our whole perspective of the treatment of schizophrenia with the approval last September 26th of xanomeline-trospium, the first muscarinic agonist approved for schizophrenia. And guess what, Gus? It's not called an antipsychotic. That word does not appear anywhere in the package label.
True.
It's its own class of medications. What's exciting about it is because it spares the D2 receptor, it also spares patients all of the D2-related adverse effects, movement disorders, hyperprolactinemia. It also doesn't have metabolic adverse effects with some very exciting signals for impact on cognition and maybe negative symptoms. It really is the future, we think, for schizophrenia treatment. It's the first novel agent we've really had in decades. Clozapine was remarkable. As you know, I wrote a book on how to use clozapine, but we've never been able to replicate it, to capture its magic in another form of another medication. But now that we've understood the muscarinic pathways and how really they regulate the core symptoms of schizophrenia, especially positive symptoms, the hope is that we may have other agents to use for schizophrenia, not based on D2 receptor binding. But I'll say, Gus, the muscarinic system is not easy to understand. It is novel. And the hope is that if you're still curious about what xanomeline does, if you don't fully understand how to use it, how to integrate it into your practice, I think it's a reason to come spend a little bit of time on a Friday morning in July in beautiful Huntington Beach and hear all about the muscarinic revolution for the treatment of schizophrenia.
I love the enthusiasm behind that, Jonathan. I know that, we're obviously going to be accompanied by Chelsea Monroe also, who's going to be elucidating a bit more about the limitations that we've seen with dopamine blockade, delayed onset of actions, metabolic side effects, and non-specificity of action that you just described right now. All of those things, unfortunately, compromise patient adherence and lead to subjective discomfort as well as further stigmatizing issues. So I love the fact that you made mention that this particular new novel agent is not considered an antipsychotic. And we obviously can't forget that close to 30% of patients who appear to be treatment resistant. That's an area that I know you've been deeply versed in and have lectured extensively about. Any other areas that you think might be useful as a teaser for people to come in and actually comprehend a little bit more about what's happening underneath the hood of the car?
Well, I think part of it is, as you've already mentioned, and I've mentioned, it's nice to now understand what the neurobiology is of the positive symptoms of schizophrenia, how dopamine underlies this, how we manage this sort of after the fact with postsynaptic strategies, but that xanomeline is really the only available viable presynaptic strategy to reduce dopamine neurotransmission. But the cool thing about it is, and you already used this word, it works selectively. It manages to reduce dopamine release in the area of our striatum where we have the positive symptoms of schizophrenia while biologically sparing effects in the motor system. No one ever thought this was really possible before, but we were just fortunate that we hit upon xanomeline and its antipsychotic properties fortuitously in the 90s during studies of patients with dementia of the Alzheimer type. That was the original use of a muscarinic agonist, was to make these people smarter. I think it's great that you understand how it works. And this also is important to understand some of its downsides. No drug is perfect. All drugs have limitations. We have a lot of muscarinic agonism going on with xanomeline, so much so it has to be paired with a peripherally acting anticholinergic trospium to try to limit some of the procholinergic adverse effects. If you want to give people the benefit of this therapy, you have to know how to initiate it. And I think that's really crucial. If people don't tolerate a medicine, Gus, they don't take it. You already mentioned that. The same is true even for a revolutionary treatment like xanomeline-trospium.
You're so right, Jonathan. And I, in fact, cannot wait to actually have a further dialogue about this. I love the fact that, but you continue to educate so many individuals that are in this particular space. We're deeply indebted to a lot of the work that you've done, Jonathan. I'm proud to actually be able to spend time with you during the conference and be able to actually help out with this particular thematic. Thank you.
My pleasure, and we hope we will see you all in Huntington Beach in July.